Welcome to CME on ReachMD. This activity, titled Decoding EGPA, a clinical deep dive into diagnosis and treatment, is provided by Clinical Care Options, LLC, doing business as Docera Clinical Education. Prior to beginning the activity, please be sure to review the faculty and commercial support disclosure statements as well as the learning objectives.
We'll start by discussing the epidemiology of EGPA. Eosinophilic granulomatosis with polyangiitis is a rare form of vasculitis affecting about 5,000 Americans annually. And from a global prevalence perspective, about 11 to 14 cases per million. This may be underestimated, but those are the best data that we have. The disease is most often diagnosed in middle-aged patients, 35 to 50-year-old, with a history of new onset or worsened asthma. But this is really the exception is more common than the rule. Patients can be diagnosed across a broad range from adolescence to later in life. And then from a comorbidities perspective, and you'll see this when we talk about diagnostic criteria as well, many patients, most if not close to all patients, 85.5% of patients with EGPA had preceding asthma as well. From a gender distribution perspective, there's similar prevalence between males and females. Some studies report higher prevalence in women, with an age-adjusted prevalence from a 2018 study of 14.7 in females versus 10.8 in males. But in general, it's a pretty even split between males and females for EGPA. Just as an overview of clinical manifestations, there's a group of manifestations that are systemic, and then a group of manifestations that are in particular respiratory. So often you'll see EGPA kind of dichotomized into the respiratory and then to the systemic and extrapulmonary manifestations. But I think the main message is that that many organ systems, as you can see here from the graphic, can be involved in EGPA. From a respiratory perspective, the manifestations do indeed include those associated with asthma, dyspnea, cough, wheeze, but not just lower respiratory, but upper respiratory as well. The sinonasal disease is quite common in EGPA. Chronic rhinosinusitis with nasal polyps is often seen. Going back down into the lung parenchyma itself, the air spaces rather than the airways, there can be pulmonary infiltrates that are seen on imaging as well. And these respiratory symptoms, particularly the asthma symptoms, often appear prior to other manifestations of EGPA. And from a systemic perspective, there are many manifestations. We'll go around the horn here on this figure, but systemic central nervous system manifestations can happen, but in particular peripheral nervous manifestations in the lower right are quite common, including peripheral neuropathy and classic mononeuritis multiplex. A few others that I would call out in particular are dermatologic manifestations. Often rashes with palpable purpura are seen. Gastrointestinal manifestations may occur as well. We talked about ear, nose, and throat manifestations. Renal manifestations, particularly glomerulonephritis, can occur as well. You can notice a theme here that some of these systemic manifestations are potentially driven by vasculitis and have similar presentations or similar manifestations to other small vessel vasculitides. And then constitutional symptoms like fevers, weight loss, myalgias, and fatigue can occur as well. And you'll be able to look at this slide as well at your leisure to kind of remember what some of the various manifestations are in EGPA. So from a disease course perspective, you will classically see written in textbooks that EGPA occurs in three stages, starting with a prodromal or allergic phase, which can potentially last for years, where people have antecedent atopic disease, in particular asthma, with or without chronic rhinosinusitis, with nasal polyps, potentially some other lurking systemic symptoms like fever, malaise. And that prodromal phase in this classic description then will evolve into an eosinophilic phase in which there's peripheral eosinophilia, often high grade noted with tissue infiltrations of various organs. And then that in turn will will go into a vasculitic phase where there's organ threat based on vasculitis with granulomatous inflammation of various organs, not just the skin, but the kidneys and peripheral nerves, potentially the GI tract as well, with more constitutional symptoms. But even though you'll see this written about a lot, and I'm talking about it here, this classic description is more often the exception rather than the rule, and EGPA can develop in any pattern of these of these buckets of phases happening with various tempos and in various mixes. So there's often not a strict linear progression through these phases, and hopefully this graphic going back and forth between the boxes represents that well. From a pathophysiologic perspective, as the name implies, eosinophilic granulomatosis with polyangiitis, eosinophils themselves have a important central pathophysiologic role in disease in EGPA. Eosinophils are driven in their development from myeloid precursors to all the way to migration into tissues and migration out of bone marrow and recruitment into tissues by IL-5. It's the most important cytokine that dictates eosinophil growth, development, survival, and movement. You can see here on this figure on the bottom in particular. So as we'll talk about in later sections, including Dr. Wechsler's section that's coming up next, that targeting IL-5 can reduce eosinophil numbers often to zero, and IL-5 receptor targeting is an important modality in EGPA treatment using monoclonal antibodies. This kind of recapitulates some of what I just said. One can therapeutically target IL-5. You can see here on the left-hand side of this figure, under normal circumstances, this is an eosinophil with the IL-5 receptor embedded in the plasma membrane. And IL-5 binds to the alpha chain of the IL-5 receptor on eosinophils, and that IL-5 signaling in turn promotes when IL-5 signals it to eosinophil precursors, signals the development to mature eosinophils, and then also signals activation of eosinophils and recruitment of eosinophils into tissues. And then on the right side of the screen here, you can see therapeutic targeting and how that may work. IL-5 itself bound by either mepolizumab or reslizumab to monoclonal antibodies against IL-5, which block signaling by binding up IL-5 and preventing its binding to its receptor. Or monoclonal antibodies like benralizumab, which bind to the IL-5 receptor itself on eosinophils and then engage natural killer cells to cause direct killing of eosinophils through a process known as antibody-dependent cell-mediated cytotoxicity. From a pathophysiologic or mechanistic perspective, EGPA and genetic perspective, EGPA is complex. It's not just driven by one thing. It's not a single gene driving EGPA that is, seen in most patients with the disease. This is really a polygenetic disease with several potential genetic determinants that confer small levels of risk. Those include polymorphisms in the HLA DR molecules. These are MHC class 2 molecules, or in a cytokine known as IL-10. There can be polymorphisms in that gene as well. But these all confer small amounts of increased risk. But there's also an important acquired determinant. Patients, this is a gene by environment type process where patients over their life are exposed to various allergens, infections, vaccinations, drugs, other toxins that might help explain the development of EGPA. And then those in turn lead to dysregulated immunity in multiple levels, which you can see on the bottom of this graphic. Eosinophils themselves, which we talked about with IL-5, dysregulated T cell subsets, including Th17 and Th2 subsets, which drive Th2 in particular, driving atopic phenomenon, and then T regulatory cells not working as well to dampen inflammation of various types in these patients. Then on the right of the bottom, important issues or problems with humoral immunity as well as reflected by some patients being ANCA positive, anti-neutrophilic cytoplasmic antibody positive, and then also these patients having elevated IgG4. So complex immunology that we're still trying to unravel from a mechanistic perspective that all go into determining development of EGPA. From a diagnosis and classification perspective, these are old criteria, but I think they're useful. There's not one set agreed upon diagnostic classification, but I think using these old 1990 American College of Rheumatology criteria can be useful because they tell us that EGPA is really a syndromic diagnosis, not a pathologic, necessarily a pathologic diagnosis. Biopsy can help. It can help make the diagnosis, but it's not necessary to make the diagnosis. Similarly, ANCA, which is not on this diagnostic schema, can help make the diagnosis, but it's not necessary to make a diagnosis. So many patients are ANCA negative. So in this old 1990 classification criteria, patients needed to have 4 of the following criteria: asthma, eosinophilia, neuropathy, pulmonary infiltrates, parasitol sinus abnormality, or indeed a biopsy. So all other diagnostic schema that you'll see that we're not going to go over in too much detail, but they all rely on a syndromic criteria-based diagnosis rather than necessarily needing a biopsy and or a positive ANCA to call a patient as having EGPA. These are the 2022 American College of Rheumatology EULAR classification criteria for EGPA. This is a different set of criteria that are used in the rheumatology community that are used in patients that you already know have vasculitis. So if you have a sense based on clinical and serologic evaluation that a patient has a small or medium vessel vasculitis, you can use this scoring system to say that somebody has EGPA or not. So you get these points on clinical and lab criteria, and if you have a score of greater than or equal to 6, that will give you a diagnosis of EGPA. So obstructive lung disease, nasal polyps, mononeuritis multiplex, these give you points. A high blood eosinophil count, this gives you a lot of points. A positive C-ANCA or an anti-PR3 antibody, this takes off points because that's more likely to be another ANCA-associated small vessel vasculitis like GPA. So speaking of the ANCA status in EGPA, about a third of patients with EGPA by many case series are ANCA positive, and ANCA positive patients tend to, but don't exclusively, have more tendency toward vasculitic phenomenon, including glomerulonephritis and peripheral neuropathy, including mononeuritis multiplex. And then the ANCA negative patients tend to have more eosinophilic type mediated pathology, including cardiac and pulmonary involvement. But these are not exclusive sorters between particular manifestations exclusively going toward ANCA negative or exclusively going toward ANCA positive. There's a lot of overlap here. So let's talk about a patient case briefly. This is Miss Stacy, a 48-year-old woman who presents to the emergency department with worsening shortness of breath and chest tightness. She reports having burning pain and weakness in her left foot for a week. She reports fatigue, migratory joint pain, and new red painful rash on her legs. She has a past medical history of asthma diagnosed over a decade ago, worsening over the last 2 years, nasal polyposis with multiple surgeries, allergic rhinitis, sinusitis, and hypothyroidism. You can see her vital signs there. Significant findings include oxygen saturation of 95% on room air. On exam, she had a decreased sensation in her left foot with a foot drop. She had bilateral nasal congestion on ENT exam with crusting. Her significant labs included an absolute eosinophil count of 44,340, high CRP and ESR, a creatinine above baseline of 1.3, some proteinuria on her urinalysis with microscopic hematuria, and positive P-ANCA, which was MPO or myeloperoxidase, anti-myeloperoxidase positive, and then she had a negative ANA, and she had an elevated IgE. So I'll talk about this case a little bit with my colleagues in a moment, but when you're evaluating a patient, like was done in this case, there are many tests you can use based on specific information provided to evaluate patients with EGPA. Here's a list here. I'm not going to go through all of them, but some routine lab findings, serologic findings for systemic inflammation can be helpful, organ-specific routine labs, immunologic testing for immunoglobulins as well, ruling out infectious disease, particularly parasites. Other hematologic tests to look for hypereosinophilic syndromes, and then other imaging tests directed at organs, particularly chest imaging and echocardiogram. But just to throw it to my colleagues, who I can introduce as they jump on camera, what diagnostic tests do you routinely use in your practice to confirm a diagnosis? So let's start with Dr. Dua, Anisha Dua from Northwestern University.
Hi everyone. Thanks Praveen for asking. I think it's really based on what the person's coming in with, and so with this patient who's having nasal crusting and obviously some neurologic symptoms, I would definitely do a neurologic workup. Neuropathic involvement for me is a really big clue for underlying diagnosis of EGPA. In terms of biopsies and stuff, I do pursue them, especially of the skin when you've got active skin lesions. The crusting is a little bit confusing because that can go a little bit, make me think about some of the other modalities like GPA and MPA, especially with that positive MPO and PNCA. So I would have done some of the workup that's already been done, but in terms of further diagnostics, I definitely start looking at the organ manifestations that the person's coming in with and deciding whether they need biopsies or fill that clinical syndrome, that you were talking about.
Great. And then Dr. Michael Wechsler from National Jewish in Denver. Hello.
Hi, great
What do
to
you
be
think?
here. Thanks for having me. Yeah, I think that for me, one of the main components of diagnostic workup is to evaluate for things that could be confusing with EGPA, making sure that you exclude infection, making sure that you exclude malignancy, making sure that you have seeked out alternative diagnoses that could be either eosinophilic in nature, drug reactions and whatnot, or vasculitic in nature. You want to go to the organs that have clinical manifestations and target them, whether it's via imaging, whether it's via biopsy, or serologically. And you could also consider alternate testing. For instance, echocardiogram and cardiac MRI as part of the evaluation for cardiac manifestations, EMG, nerve conduction studies for neurologic manifestations.
Fantastic. Thanks. And I'll see you both in a little bit here. All right. So I'm going to quickly go through a couple more slides. I'm going a little long and I'll pass off to my colleagues, but the role of biopsy in diagnosing EGPA, I think I've already said, is not essential to make a diagnosis, but if it's feasible, we recommend that you do it. And that will be, organ specific based on where somebody's disease is manifesting itself. That could be ENT, it could be a lung biopsy, could rarely be GI tract, often skin, often nerve, sometimes kidney as well if somebody has an active urinary sediment. All right, so we just looked at this case a moment ago, and we're going to focus in on that. The skin biopsy in this case, which is added information, reveals necrotizing small vessel vasculitis with an eosinophil-rich infiltrate. So in this case, a biopsy helped make the diagnosis of EGPA, though it's not always necessary. So let's go with a polling question here. Which of the following clinical features is most strongly associated with ANCA-positive EGPA? Cardiomyopathy, alveolar hemorrhage, nasal polyposis, eosinophilic pneumonia, or gastrointestinal involvement? I'll give you a second. All right, let's see what people said. So very widespread of on the polling question, and let's look at the answer here. So alveolar hemorrhage, which is a very vasculitic manifestation, is more strongly associated with ANCA positive EGPA. So that's something to kind of remember. All right, so I think we did a lot of discussion already. So maybe I will we'll put a pin in these and talk about them at the end. But just to talk about what some of the questions might be. What red flags prompt EGPA? How do you differentiate EGPA from other hypereosinophilic conditions? What role does ANCA testing play? Which organ involvements most frequently lead to a diagnosis of EGPA? So that's all food for thought for the end of the program. We'll do these post-test questions as well. You've seen these. I won't read them fully, but this first one, this patient had a adult onset asthma, purpuric rash, eosinophil count of 3,200, ANCA positivity. She had mononeuritis multiplex, and which pathologic process most directly explains the patient's neuropathy and renal findings? So go ahead and answer. Okay. Let's see the responses. Okay, so we're starting to triangulate a little bit more on the answer of C, Th2 cytokine driven eosinophilic inflammation. I'm not sure if Th1 inflammation is also, or Th17 mediated neutrophilic inflammation is also very important in vasculitic manifestations as well. So this is a little bit of a there's a lot going on in EGPA, but for here we've given you Th2 cytokine-driven eosinophilic inflammation. Okay, the second post-test question. So this patient, we were talking about the EULAR score. Which single additional finding would most increase this patient's EULAR score? Hematuria, negative PR3, nasal polyps, or elevated total IgE? Okay, let's see the answer. Okay, people said hematuria. It's a pretty widespread here as well. So the EULAR score is actually quite the only thing here that gives you positive results is the nasal polyps on endoscopy. And the negative PR3 and ANCA doesn't give you positive numbers, but it avoids a negative score on the EULAR scoring. All right, and then finally the last one. Oh, okay. We don't have the last one. So now I'm going to pass it off to Dr. Wechsler, who'll be talking about recent advances in EGPA treatment.
Hello. Let me rejoin
I'll come
here.
off camera as you go on. There you go.
Perfect. Thanks so much, Praveen. Great to be here with you all. Again, I'm Mike Wechsler from National Jewish in Denver, Colorado. One of the most exciting things about EGPA is the fact that we've had so many advances in the management of EGPA just in the last couple of years, and it's really revolutionized the way we manage our patients with EGPA. So what I'll do is I'll go through some of the past and future therapies and some of the new guidelines that have emerged over the last couple of years. Here we go. So, sorry, seems like the slide thing is having a mind of its own. So, first of all, in terms of currently available therapies, we generally think of treating EGPA with systemic glucocorticoids and cyclophosphamide, and those have been used historically for remission induction. And in the last decade or so, there's been addition of rituximab as part of that, based on other studies in vasculitis, other vasculitides, including GPA, where rituximab was shown to be effective in terms of inducing remission. Alternative options that have been used historically include other disease-modifying rheumatologic agents, including methotrexate, azathioprine, and mycophenolate. However, the only two approved therapies for the management of EGPA include the anti-IL-5 agents mepolizumab and benralizumab. So review these therapies and some of the studies that led to their approval in EGPA, as well as some of the guidelines. In terms of guidelines, they aren't completely updated. They haven't been updated in a few years. However, there were some guidelines established in 2021 by the American College of Rheumatology and in 2022 by the European League Against Rheumatism. For active non-severe EGPA, the ACR guidelines advocate for utilization of glucocorticoids with mepolizumab or methotrexate, azathioprine, or rituximab. Again, these are for patients with active non-severe EGPA. We're talking about non-severe, we're talking about non-life-threatening and non-critical organ-threatening disease. For management of patients who have relapses and who have been treated with methotrexate, azathioprine, or any of the other agents, the recommendation is to add glucocorticoids and mepolizumab. For non-severe disease relapses after mepolizumab or rituximab, then one should consider other immunomodulatory approaches because those patients are obviously not responding. The 2022 EULAR guidelines evaluate patients, again, if they have non-organ life-threatening disease and active EGPA, then recommendations start mepolizumab. This was before the approval of benralizumab for this indication. And if they're not relapsing then and or have refractory disease, then one could consider, if they are relapsing or having refractory disease, consider adding glucocorticoids. The goal of glucocorticoid management is to try to get patients down to as low a dose as possible so as to prevent many of the side effects of glucocorticoids. When we look at the comparison of these two sets of guidelines, there are some differences that are a little bit nuanced in terms of induction, maintenance, and use of glucocorticoids, as well as for management of relapses. But in general, for more severe disease, for severe EGPA, the recommendations are to utilize glucocorticoids with either cyclophosphamide or rituximab, and then for maintenance therapy, to switch to methotrexate, azathioprine, or mycophenolate, and consider mepolizumab in the 2022 EULAR guidelines. The goal is to try to taper down glucocorticoids in all these patients, getting down to as low a dose as possible. And for management of relapses of these patients with severe disease, it's recommended, if the patient wasn't receiving rituximab, then to consider using rituximab. There aren't data for the anti-IL-5 therapies because they weren't tested in this patient population. And much of the data for severe EGPA is based on the rheumatology literature for other vasculitides. The data resulting in the approval of mepolizumab, the anti-IL-5 therapy that reduces eosinophils, was based on the MIRROR trial. This was a study looking at mepolizumab, an anti-IL-5 therapy that was previously approved in asthma, in patients with relapsing or refractory EGPA. Patients were randomized to receive 300 milligrams of mepolizumab, which is different from the 100 milligram dose, for up to a year. And it was demonstrated that when we looked on the left-hand side, the proportion of patients who were in remission, you can see the odds ratio of going into remission, which was defined as having a Birmingham vasculitis score of 0 and being on 4 milligrams or less of prednisone. You can see that the odds ratio is 6 times higher with mepolizumab compared to placebo. And when you look at the relapse rate in this patient population, again, a relapsing or refractory population, the time to relapse was significantly increased with mepolizumab, and the rate of relapses was cut in half by about 50%. So mepolizumab was safe, well-tolerated, resulted in significant reduction in relapses, significant increase in the proportion of patients who were able to achieve remission. Some real-world data have been published on the left-hand side with 100 milligrams of mepolizumab, on the right-hand side with 300 milligrams of mepolizumab. And you can see that when you follow these patients in the real world treated with mepolizumab, there's a significant proportion of patients who are able to achieve quite a good response. Let's focus on the FDA-approved dosing of 300 milligrams every 4 weeks. You can see that by 6 months, close to 70% of patients had a partial or complete response, and that proportion increases such that by 24 months, 92% of patients achieve a partial or complete response. And this suggests that there's significant efficacy with targeting IL-5 and targeting the eosinophils. The Mandara trial was a head-to-head comparison between benralizumab, an IL-5 receptor antagonist, with mepolizumab, an anti-IL-5 therapy. And what we did was we administered 30 milligrams of benralizumab monthly or 300 of mepolizumab monthly and demonstrated that benralizumab was non-inferior to mepolizumab in terms of the proportion of patients who ended up relapsing and the proportion of patients who ended up going into remission. Another important feature of this clinical trial was the glucocorticoid sparing that was observed with both benralizumab and mepolizumab. When we looked at the proportion of patients who were able to reduce their corticosteroid dose by 50% or more at baseline, you can see that mepolizumab reduced 74% of patients receiving mepolizumab and 85% of patients receiving benralizumab were able to cut their steroid dose in half or more. And when we look at 100% glucocorticoid withdrawal, so people able to come off of glucocorticoids, 41% of benralizumab patients and 26% of mepolizumab patients were able to come off of glucocorticoids completely. 70% of patients, close to 70%, were able to get their glucocorticoid dose down to 4 milligrams or less. So really important, reduction in exacerbations, prevention of relapses, getting patients remission and off of glucocorticoids. So those therapies have just emerged in the last couple of years, approved by the FDA, but there are also several other therapies that are in development. Depemokimab is a long-acting anti-IL-5 therapy that's been in development now for both asthma and EGPA. Results of this study should be available next year. But this therapy is an anti-IL-5 that's administered every 6 months. So imagine that, taking twice a year of therapy to block your eosinophils. Tezepelumab blocks TSLP, or thymic stromal lymphopoietin. Already approved in asthma, it's undergoing a study in EGPA as well. And NS229 is a JAK inhibitor that works a little bit further downstream on all the type 2 cytokines and more, and may be beneficial in patients with EGPA. So let's take a quick look at a case. Here's Mr. Samuel, a 55-year-old gentleman who had moderate persistent asthma, nasal polyps, and his respiratory symptoms became worse and worse. He presented to the outpatient clinic stating that in addition to worsening respiratory symptoms, he had bilateral foot numbness and weakness, and this resulted in difficulty walking. He also had a painful red rash on his shins, fatigue, myalgias, fevers, shortness of breath, and however, he didn't have any new infiltrates. In addition to his past medical history of type 2 diabetes, he was found to have marked eosinophilia, so eosinophil count of 4,000, with elevated inflammatory sedimentation rate and CRP markers, positive p-ANCA, again, myeloperoxidase positive, normal renal function, no urinary abnormalities, a skin biopsy that showed leukocytoclastic vasculitis with eosinophilic-rich infiltration, and he had nerve conduction studies that showed mononeuritis multiplex. So this is a very typical case, meeting all the key features of EGPA. He had no cardiac or renal involvement in initial workup, and he was diagnosed with ANCA-positive EGPA. So what's the most appropriate therapy for Mr. Samuel at this point? Oral prednisone, 1 milligram per kilogram a day, prednisone with methotrexate, prednisone with cyclophosphamide, or mepolizumab monotherapy? Take a moment to answer. Okay, let's see how people did. So interestingly, a lot of people wrote mepolizumab monotherapy. However, in this patient who had acute acute presentation of EGPA, you really want to get the patient under good control. And so I think the appropriate response would be prednisone with cyclophosphamide for this type of patient. Mepolizumab hasn't really been tested in the acute setting presentation of patients with EGPA. There we go. Well, at least I got it right. All right, next. All right, so during follow-up at 8 weeks, his asthma is better controlled, his skin rash resolved, and his neuropathy plateaued. However, he had significant insomnia and worsening glucose control. So, how do you interpret this information? Well, probably as a result of some corticosteroids. What's the next appropriate management for him? Would you A, taper his prednisone rapidly, B, switch from cyclophosphamide to azathioprine, C, add mepolizumab and taper cyclophosphamide, D, discontinue all immunosuppression and monitor? Take a moment to answer. Let's see how people did. Okay. Here, a lot of people said add mepolizumab and taper cyclophosphamide. I actually think that adding mepolizumab is not a bad answer, but I think switching from cyclophosphamide to azathioprine is currently the standard of care for these kinds of patients. You don't really taper the cyclophosphamide. You want to get people off of cyclophosphamide to try to prevent long-term complications. Obviously, tapering prednisone rapidly can result in worsening of his underlying disease, and discontinuing all immunosuppression and monitoring could be a problem as well. So I think the answer here ought to be switching from cyclophosphamide to azathioprine. Mepolizumab could be an option as well, but I don't think I would taper the cyclophosphamide necessarily. Okay, so let's get my colleagues on the line here. Let's have a quick discussion. Let's do a rapid fire with you guys. So, Praveen, let me start with you. For a patient like Mr. Samuel with a 5-factor score of 1 due to neuropathy, what factors push you towards cyclophosphamide versus rituximab?
That might be a better question for Anisha, but I'm not
I
using the
want to challenge
5-factor
you,
score.
Praveen.
Yeah, I'm not using the 5-factor score super often, but I think refractory renal failure might push me towards cyclophosphamide over rituximab. But again, I'm going to chicken out and see what
You can
what
use the
Dr.
phone a
Dua has
friend
to say.
option.
Yeah, I'm phoning a friend on that one.
Thanks for being your friend. I think that there's decent data for both cyclophosphamide and rituximab with patients with an elevated 5-factor score. So I think with neuropathy, either are reasonable to use. There's more recent data from the RIOVAST trial that compared both of these agents in patients with an elevated 5-factor score, so severe organ involvement, which includes mononeuritis multiplex and cardiac involvement and all those other things. So I would use I think it's reasonable to use either of these agents. I've been leaning more lately towards using a lot more rituximab after the RIOVAST results were published, and I think ACR guidelines say to use cyclophosphamide in cardiac cases, and EULAR guidelines there's a little bit of differences. So I think you can use either, and both of those societies have evidence for both drugs.
Okay. Sounds good. Sounds like you won't be faulted for trying either one. And at what point would you consider transitioning from induction to maintenance therapy? And which agents do you prefer from once you're switching?
I'll just keep going with that for a second. And so I usually, if I'm using cyclophosphamide, I'll use about 3 months of it. And if they're doing stable, then I'll switch them over to their maintenance therapy. Rituximab, if I'm inducing them with rituximab, then I would switch over at the 6-month mark. I might consider, if I'm using rituximab up front, if they do well, to continue rituximab. There's some data that will be coming out slowly about rituximab as a maintenance agent, and that's starting to be presented. But if I'm switching them over to a DMARD, I usually will switch them over at around the 3-month mark if they're doing well. And I would usually use either azathioprine, methotrexate, something like that, I will sometimes add mepolizumab, especially if they have some of those eosinophilic or Th2 manifestations, if I can get it approved.
So why not add mepolizumab? Go down to the third question there. Why wouldn't you add mepolizumab or switch to mepolizumab?
Praveen, you
Yeah,
want to
why
take it?
not indeed, right? I think you don't necessarily have to feel like you're strictly in the maintenance phase before you add it. I think you can start it on the earlier side, and that's perfectly reasonable.
I agree that it's totally reasonable to do. I think the coverage is the hard issue when you're trying to get two biologics covered. So if you're doing rituximab, but getting mepolizumab from a functional standpoint can be hard to get approved. But I think there's like pathophysiologic data that definitely shows it would be helpful. I usually don't use that as a maintenance agent after severe disease in most cases, just based on the guidelines, which I don't totally agree with, and they're based on mediocre data. But yeah, I
And
kind of
not
use.
necessarily even in EGPA. And so, is there a potential role for using the anti-IL-5 agents up front, even before or instead of cytotoxic therapy? What do you guys think? Praveen.
I would say probably yes. But we need to have evidence generation around that. I think, the asthma and COPD literature are starting to suggest that you can give IL-5 receptor therapy in acute settings. Perhaps, that might be a viable strategy to generate some evidence around in the future for EGPA patients, but we're not there yet. But I think it's a good hypothesis.
Sounds good. Any other thoughts, Anisha?
Yeah, patient profile wise, definitely a non-severe disease. I mean, there's good data there. So in patients who don't have an elevated five-factor score, I think there's definitely data to support using mepolizumab upfront.
Sounds good. All right. So, let's just transition here briefly to the role of some immunosuppressive agents in EGPA, including for severe EGPA. We've already talked about cyclophosphamide and rituximab, particularly in patients who are ANCA positive. There may be a role there. For remission maintenance, azathioprine, methotrexate, mycophenolate, and rituximab have all been utilized. And for non-severe EGPA, there are some data supporting use of those agents for remission, but they aren't used necessarily in routine clinical practice. The anti-IL-5s tend to be utilized more now for non-severe EGPA. I think we have to balance what we know, what's been in clinical trials in EGPA, with historical remnants from other vasculitides and not be necessarily bound by the history and consider more what the potential benefits are and potential risks as well. And so these are all important questions I still think need some answers. Okay. All right. Well, let's just go on a couple of quick cases here. 43-year-old woman with adult onset asthma, rhinosinusitis, nasal polyps, prior biopsy showing eosinophil predominant small vessel vasculitis, has relapsing non-severe EGPA, and is taking prednisone 15 milligrams a day and methotrexate 20 a week, but flares when prednisone gets down to less than 10. Her eosinophil count is 1700. She's ANCA positive, PR3 negative. Would you increase methotrexate to 25, start anti-IL-5, switch to azathioprine, and hold the biologics, begin rituximab with pulse methylprednisolone? Next, let's see what you guys think. Okay. So some of you said begin rituximab with pulse methylprednisolone. Some of you said start anti-IL-5 therapy. And I think these are reasonable choices. Again, she has been doing well on current standard care therapy. This is the exact type patient that was enrolled in both the MIRA and Mandara trial. These are patients who would benefit from anti-IL-5 therapy. She flares, she has relapsing disease that has been difficult to taper down, and it would allow for steroid withdrawal. So in this case, I would go with anti-IL-5 therapy. I'm going to pass the baton on to Anisha Dua. Welcome.
Thanks, Mike. And in the last few minutes here, I'm going to talk a little bit about partnering with patients. in terms of achieving and maintaining remission in EGPA. And so we all know that the burden, we've talked about all the different disease manifestations, and the burden of EGPA can really be very severe, multi-organ involvement, resulting in a lot of glucocorticoid use with all of the side effects that we all know we're trying to counsel our patients on and manage. A lot of asthma exacerbations, which land patients in the ER, as well as hospitalized. And so this really drives up healthcare utilization costs. And the fact that we don't recognize this disease early can also contribute to this burden, because the longer you wait to try to treat that inflammation, the more damage that's accruing and the more kind of lack of access to the medications that need to be implemented happens. So there have been a couple of interesting studies looking at the patient perspective on the burden of EGPA. There was a qualitative interview of adults in the Mandara trial that had EGPA, and they reported more than 35 symptoms reported as bothersome. It's a lot of different symptoms, and all of these patients reported trouble with breathing and shortness of breath. Most of them reported coughing, wheezing, neuropathy, fatigue, and nasal congestion and discharge. And you can imagine that having all of these symptoms can lead to significant impact on your ability to function as a regular human, to work, to exercise, to sleep well, to engage in social activities. And so it's just sort of really showing the patient perspective on how frustrating, whether it's life or not life-threatening, the disease can be in terms of their functioning. There was another exploratory study using social media that found that a third of patients with EGPA had significant issues with diagnostic delays and misdiagnosis. And the reason that's really important is because if we're unable to recognize and diagnose these patients, then we cannot get them on the appropriate treatment, and we're treating them with multiple courses of steroids, again, with those resultant side effects. And if we can't get that diagnosis, then it's hard to access a lot of the newer medications that have now been shown to really help control this disease in these patients. So this, again, is just sort of a picture of how the symptom burden in EGPA can really be significant and diffuse. You can see the numbers, and I won't go through them, but constitutional symptoms like skin manifestations, GI, respiratory, ENT, cardiovascular, neurologic, other, and a lot of these bars go all the way to the end. And so you can see the percentage of patients reporting many of these different symptoms is really, really high. And so I think it's just important to note how multisystemic this disease is, and depending on what perspective you are, what type of provider you are, you might be dealing with different pieces of this. But from a patient perspective, their whole body can be involved. And I always tell people with small vessel vasculitides, we have small blood vessels everywhere. And so, any of them can be affected and can impact your quality of life. So when it comes to having these burdens, you really want to sort of leverage the patient perspective and what's bothering them the most in terms of deciding how to pursue treatment and how to talk to them about what treatments make sense for them. And the best way to do that, of course, is to communicate with them and see your patients and talk to them about what is bothering them and what the different pros and cons of different medications would be, how they're monitored, how they're administered, and talk to them about what they really value. So make it relate to their actual life and their functioning limitations, to help them see why these, immunosuppressive medications or steroids which have a lot of side effects potentially, can really improve their quality of life and what makes sense for them in terms of their frame of reference. Once you do that conversation and then really explain it to them, then they're much more likely to stick with that therapy and that regimen. And you come up with kind of how you're going to follow up, what labs are going to be needed, what types of imaging studies or different types of studies, PFTs, et cetera, are going to be needed to really monitor their disease. And that's really kind of important and critical in terms of doctoring these patients and making sure that they feel like they are weighing in on that entire process and understand the benefits of these treatments that they probably haven't heard about, and they haven't had friends that necessarily have this diagnosis. So it can be a scary place for a patient to be, and it's just important to remember as a provider to be able to connect with that kind of lack of information and be able to give it to them in a meaningful way. So risks and benefits of glucocorticoids, again, I know we don't have much time left in this talk, so I won't go through these because I do feel like we really understand them quite well as providers. We use a lot of steroids. It's a double-edged sword. They work really well in terms of controlling inflammation, but they have a boatload of side effects, which are listed here. And there are many challenges that all of us have dealt with in our patients who are on these chronic glucocorticoids, ranging from severe things like new onset diabetes with wound ulcerations and hip fractures, as well as other things that might not be quite as severe in some ways, but also very life limiting in terms of trouble sleeping, agitation, difficulty kind of focusing, and it's, we're all pretty familiar with those. So how do we manage this? Beyond kind of figuring out what the patient specifically needs and working with them to minimize those comorbidities, we want to obviously monitor for treatment-related adverse events, try to preserve their organ function to improve survival and reduce mortality, which has been really improved in the last, I'd say, 10 years with the new trials actually focusing on EGPA patients, regularly monitoring for disease prevention or progression, preventing infection, because we know as we use these drugs, they can increase the susceptibility to infections, and also the disease itself increases susceptibility to infections. And then managing peripheral neuropathy can be a really, really tough one for patients to deal with and manage because those symptoms can really last very long and be quite debilitating. And ask them about their psychological and lifestyle needs. So what do they do in terms of social support? What do they do in terms of work? And how can you help make those specific components more functional for the patient? And this is not something that you are solely responsible for. They need to have a team. And that is why a lot of vasculitis care happens in some of these specialized centers. And it can be difficult when you don't have access to some of these centers. But because these diseases are so multi-organ, it's really important to have other people on board helping to monitor some of the other manifestations of the disease. And you can see that a lot of these different specialties are listed here. And I, again, won't go through all of them in detail. So we'll go quickly to a case. Miss Martin is an elementary school teacher. She has persistent asthma and nasal polyps for several years. She began feeling overwhelming fatigue, developed a painful rash, and lost sensation in her right foot. She could no longer stand comfortably in the classroom or keep up with her young students. After weeks of bouncing between specialists, a rheumatologist ordered the right labs, yay, rheumatology, and a biopsy, and her labs showed an elevated eosinophil count, positive MPO-ANCA, mononeuritis multiplex, biopsy-proven eosinophilic vasculitis. So she got the diagnosis of EGPA. She was started on prednisone and mg per kg a day, along with oral cyclophosphamide with close monitoring by a multidisciplinary team. The early days were difficult, nausea, insomnia, and the emotional weight of the diagnosis. So now she comes to follow up 3 months later. Her rash faded, her breathing improved, and her blood counts normalized. She was still on low-dose prednisone and ready for the next step. She and her rheumatologist discussed options, and she was hesitant about long-term steroid use, reasonably talking about her weight gain and her mood swings and how they were really negatively impacting her life. And now she's completed 3 months of induction therapy with prednisone and cyclophosphamide. She's in clinical remission and expresses concern about the steroid use. What should we do next? The options are continue prednisone and cyclophosphamide for another 3 months. B, discontinue all treatment and monitor for relapse. C, begin mepolizumab and taper off prednisone. D, switch to methotrexate and maintain prednisone at 5 milligrams a day. Or E, replace prednisone with azathioprine and stop cyclophosphamide. And I know the poll has been sort of sent out, so if I'll give you just a few seconds to answer it because we're kind of at time. All right, you want to go in advance? All right, so the majority here said begin mepolizumab and taper off prednisone with a little bit of a spread between some of the other options here. So that is correct, but you want to begin mepolizumab and taper off of prednisone because she's having a lot of those side effects and she's ready for switching over to her maintenance agent. I don't know that we have necessarily time for some of these discussions. I guess I'll ask you, maybe each of you, if you guys want to come on camera, one of them, and then we can move on. So I guess Praveen, you're on camera. How do you tailor? I'll just do the first two. How do you tailor steroid tapering in patients with EGPA and early signs of steroid toxicity, or how do you approach the issues that come up early on when patients are having all these steroid-related issues?
I mean, I think it's a tricky issue. First of all, with steroid tapering, I feel like, you taper as quickly as possible as symptoms allow. I don't go necessarily with the cookbook to try to eliminate some of those or limit some of those steroid toxicities. And, especially with early signs of steroid toxicity, that should be, again, another, kick toward trying to taper as aggressively as possible. Sometimes that means putting adjunct agents on as well that you might not have started that early. So that's the basic.
Yeah, no, I think that's fair. And then Mike, I'll ask you the second one. This is a really tough one, actually. Persistent neuropathy post-treatment. How do you distinguish between damage versus active disease? I think this is something that comes up a lot in clinical practice. So how do you approach that?
Yeah. So, I think it's important to work with a neurologist, and also you can utilize some objective criteria from EMGs and nerve conduction studies and evaluate whether or not there's been progression over time. And sometimes it's just damage that is just going to persist and persist, and the patients will complain. You just have to try to reassure them that, things will, as long as things aren't progressing and not getting worse, then they should be okay, and things might slowly get better.
Yeah, no, I totally agree. I think that's one of the things that's the slowest to improve, and it takes so long, but you can see it. It just requires a lot of patience and medications to kind of control the pain. So I'll move on because, again, with time. So post-test question, how confident are you in your ability to integrate shared decision-making in the management of patients with EGPA? Not confident, somewhat not confident, somewhat confident, confident, or very confident. I'll give you 5 seconds. All right, go ahead. All right, so we've moved up a little bit. We have more somewhat confident and a little bit of confident even. So that's great. And nobody is not confident, and that's important. We'll go to the next one. So the real key takeaways here, and I know we covered a lot of data, is that EGPA is a rare disease. It's challenging to diagnose and manage because it can present in so many different ways with different levels of severity. It has a really large burden on patients. It affects their physical health, their emotional health, their quality of life, and just their everyday functioning. And whilst glucocorticoids really remain a major cornerstone of EGPA treatment, we know the many issues that can come with using these short and long term. And agents that are targeting IL-5 in clinical trials really focused on EGPA, which is wonderful because many of the other trials have demonstrated efficacy and safety in the treatment of EGPA, and they allow us to really reduce or discontinue systemic glucocorticoid therapy. And in terms of questions and answers, I think there was some question in the box in the Q&A, and I think it was answered in that area. It was just about how long to wait after rituximab before starting mepolizumab, and would you check a CD19 or 20 level first? And Praveen responded to it. I don't know if you guys can see that, but I also he said he personally starts at 6 months and not based on CD19 or 20 count. I agree. I don't really follow the CD20 count for deciding when to redose rituximab. But in terms of initiating mepolizumab, I don't think you necessarily need to wait till the 6-month mark at all to start it. And in really sick patients where I'm inducing them with rituximab, I might use mepolizumab upfront. Again, it has more to do with insurance coverage than it does with what I think the impact on the disease would be.
You have been listening to CME on ReachMD. This activity is provided by Clinical Care Options, LLC, doing business as Docera Clinical Education. To receive your free CME credit or to download this activity, go to reachmd.com/CME. Thank you for listening.